Finally, the last disorder of hypertensive case, we have eclampsia. So, here we are going to take a look at etiopathogenesis, clinical features, diagnosis, differential diagnosis, management of a pregnant female with preeclampsia at 36 weeks of gestation. This can come as a long answer, so very important, just like the rest of the topics here. Etiopathogenesis. Eclampsia is a severe complication of preeclampsia. We have seen this earlier in the previous video, characterized by the onset of generalized tonic-clonic seizures and or coma in pregnant women without any prior neurological disorder. It results from cerebral vasospasm, endothelial dysfunction and increased vascular permeability leading to cerebral edema, ischemia and hemorrhage. So, mainly it is somewhat, this is the pathology also included over here. So, cerebral vasospasm, endothelial dysfunction, so the endothelium is not functioning properly, and inflammation kind of a state, not exactly inflammation, but vascular permeability increases. So, that is seen in this one, what is it? Inflammation, right? Inflammatory kind of state. So, overall leading to cerebral edema, ischemia and hemorrhage, but it is not inflammation. Okay, it is a neurological disorder where vascular permeability occurs and which leads to cerebral edema, ischemia and hemorrhage. Major pathophysiological mechanism. So, anoxia, cerebral edema, cerebral dysrhythmia, excessive release of excitatory neurotransmitters, loss of cerebrovascular autoregulation. First one, anoxia, cerebral vasospasm increases vascular resistance, causing decreased oxygen delivery to the brain. So, this one is obvious. So, spasm of the vessel, no oxygen. Cerebral edema, increased capillary permeability due to endothelial dysfunction and inflammation. Yes, inflammation. Yes, inflammation is there. Yeah, I thought it is somewhat, it was not right to mention it here, but it is the case in this particular topic. Yeah, next coming to cerebral dysrhythmia. Hypoxia and ischemia lead to disorganized electrical activity resulting in convulsion. So, this one convulsions, this makes sense because of this. Yeah, it is explained very nicely. Excessive release of excitatory neurotransmitters, glutamine in this case, leads to neuronal hyperactivity and seizures. So, one is by hypoxia ischemia and second one is by increased release of these neurotransmitters. Loss of cerebrovascular autoregulation results in forced vasodilation and vasospasm. So, loss of cerebrovascular autoregulation is gone. So, because of that, vasodilation and vasospasm can occur leading to hypertensive encephalopathy. So, hypertensive encephalopathy is secondary to loss of cerebrovascular autoregulation. So, we have looked at the etiopathogenesis. Now, we are going to look at the clinical features. So, eclamptic seizures are epileptiform and progress in 4 stages. So, we have different stages here. First one, premonitory stage, next one tonic stage, next one clonic stage, last one is the coma stage. So, just by looking at the name we can imagine something like what it might mean. Premonitory phase, the preliminary phase, tonic phase, the tone is what we look at, and next one clonic. So, clonus and coma, we know what it means. So, premonitory phase, twitching of facial muscles and periorbital area, facial muscles and periorbit, eyes roll up and fixate like this and it lasts for 30 seconds. So, that is the first stage, premonitory phase, premonitory stage. Second stage, tonic stage, the whole body enters a tonic spasm, opisthotonus. Where else have we learnt about this? I think it was strychnine poisoning or tetanus. It is confusing, it is always confusing. Yeah, but we have learnt it over there. So, this is somewhat similar. Cyanosis and respiratory arrest lasts for 30 seconds. So, whole body enters a tonic spasm. Let us take a look at the diagram, that would be better. Yeah, so this one, yeah, tetanus was the one. Yeah, cyanosis and maybe one strychnine. Yeah, anyways, lasts for 30 seconds. So, respiratory arrest, so cyanosis. Clonic, so even this one is 30 seconds. Clonic stage, involuntary contraction and relaxation of muscles, tongue biting, frothing and stertorous breathing. So, let us See what this means. Stertorous breathing. Noisy, heavy, snoring like breathing caused by partial obstruction of upper airway. Okay. Lasting for 1 to 4 minutes. So, this one is quite long, 1 to 4 minutes. Involuntary contraction and relaxation of muscles, tongue biting, frothing and stertorous breathing. Lasts for 1 to 4 minutes. So, this was the third stage, premonitory stage, tonic stage, clonic stage. Finally, we have coma stage. Patient remains in deep coma after seizures. Confused state may progress to status epilepticus. So, either it is in deep coma or confused state which might progress to status epilepticus. Yeah. So, these other 4 stages we know what those mean now. Additional symptoms: severe headache, blurred vision or scotoma, oliguria, epigastric pain, hypertension, proteinuria, which is somewhat similar to the previous topic what we have learnt, and it is being repeated again. So, by now we should be thorough with the additional symptoms of hypertension, the complication side of things. Coming to the diagnosis, so this is the most complicated state, right? So, these are the additional symptoms of this complicated state. Coming to the diagnosis, yes. Clinical diagnosis, lab investigation. So, clinical diagnosis: sudden onset of seizures or coma in pre-eclamptic woman, blood pressure greater than or equal to 160/110, presence of severe proteinuria which is greater than 5 gram every 24 hours or greater than or equal to 3+ on dipstick test. Coming to lab investigations, there is CBC, LFT, RFT, uric acid, serum uric acid, coag profile, urine analysis, MRI, CT, brain. So, thrombocytopenia less than 100 K, we have seen it earlier. AST, ALT greater than 70 again. Serum creatinine greater than 1.1 milligram per deciliter, again the same thing. Elevated in severe cases, uric acid, yes. DIC and 3+ on dipstick urine analysis, the proteins. And in case of brain imaging, indicated if focal neurological deficit persists post seizure. So, that is what do we see? We can see edema. Coming to differential diagnosis, epilepsy, hypertensive encephalopathy, intracranial hemorrhage, cerebral venous thrombosis, meningitis, encephalitis, posterior reversible encephalopathy syndrome. All this high level, I am not going into it because I am feeling sleepy too. Anyways, if you would like to learn more about these things, you are free to do what I did earlier for the rest of now I feel like doing it. Since I am recording this, I can't escape. Why? What do each mean? Yeah, let's look at it one by one. So, this one we know, this one we know. Yeah, papilledema and all that caused by severe uncontrolled hypertension leading to cerebral edema. So, this is a part of that. Yes, intracranial hemorrhage, so bleeding inside the skull, SAH, ICH, subdural hematoma, sudden severe headache, neurological deficit, seizures. So, seizures, that is what we are looking at. Cerebral venous thrombosis. Yeah, so it was obvious, we didn't have to search it here. Yeah, in this case seizures are seen. Posterior reversible encephalopathy syndrome, reversible brain condition caused by hypertension, eclampsia, renal failure, immunosuppressive drugs. Pathophysiology, failure of cerebral autoregulation leading to brain edema. We are not looking at this, but if somebody wants to, they can take a look. Free knowledge for everyone, free. Yeah, coming to management at 36 weeks of gestation. So, yeah, coming back, it is mainly about mimicking eclampsia via seizures. So, eclampsia equals hypertension plus seizures. So, seizures is what we are looking at. Management at 36 weeks, immediate management, seizure control, blood pressure control, delivery planning, and finally postpartum monitoring. Immediate management, patency of ensure airway patency, place the patient in left lateral position to prevent aspiration, Supplement oxygen 10 later via face mask. Suction secretion to prevent aspiration. IV access with crystalloid fluids, Ringer's lactate, NS. So these are the immediate measures. Next, coming to seizure control, there is magnesium sulfate therapy. Loading dose 4 gram IV over 15 to 20 minutes, followed by 5 gram deep IM in each buttock. 4 gram IV over 15 to 20 minutes, followed by 5 gram deep IM in each buttock. Maintenance dose 1 to 2 gram per hour, IV infusion for 24 hours post seizure. And monitoring for toxicity, again absent deep tendon reflexes, respiratory rate less than 12 per minute, and urine output less than 30 ml per hour. So this is the regimen. What is it called? I think it's called Bisgard's or something. I think it's Bisgard's regimen. Bisgard's. Maybe spelling error or something. Bisgard's. No, it is the same. That is for this one. Then what is it called? Magnesium sulfate. What regimen is it? Named regimen. Yeah, this one. Yeah. I'll add the name. It's very important. They keep asking this. That's why I remember this. So I'll make a new one. Yeah. So this was the one. Yeah, Bisgard's regimen. It's not Bisgard's. It is this Pritchard's regimen or Zuspan regimen. I'll add it here. That is the naming of this particular regimen. So let's take a look. Sorry about the mistake. Yeah, so it was a very bad mistake. Yeah, Pritchard's regimen, 4 gram IV, slower 5 to 10 minutes. What is it? 15 to 20 minutes. Which one is it? Yeah, so it is a combination of both of these. This one is directly from the textbook, so better to use this and use this in the brackets, like Pritchard's regimen / Zuspan regimen, because it's almost the same, almost. So 5 gram deep IM in each buttock. Here it is 5 gram IM in 5 gram in each buttock. Yeah, this is the one. But here it is 15 to 20, which is something taken from the other one. Yeah, so this one slowly, better to use the Pritchard's regimen. This one is this is the one. So this one I will just highlight it here. Pritchard's regimen, very important. They keep asking it every single day in the wards. Maintenance dose 5 gram IM every 4 hours. I just remember the words. Every 4 hours in alternate buttocks and continue for 24 hours after last delivery or seizure. Coming to blood pressure control. So we know the drugs labetalol, hydralazine and nifedipine. Labetalol 20 mg IV bolus, repeat every 10 minutes if BP remains greater than this number 160 over 110, and hydralazine 5 mg IV every 30 minutes as needed, and nifedipine 10 mg oral, repeat every 30 minutes if needed. So this one repeat 30 minutes, this one repeat every 10 minutes, and even the dose is very high, 20 mg IV, sorry, here it is 5 mg IV, here it is 10 mg oral. Coming to delivery planning, immediate delivery is indicated after maternal stabilization if cervix is favorable. Induction of labor using oxytocin or PGE2 gel. PGE2 gel, is it dinoprost? Because we remember making a nice mnemonic, dino meaning dinoprostron, yes, dinoprostron. Cervix is if cervix is unfavorable or fetal distress is present, emergency C-section. So cervix favorable, we do this, not favorable, we do C-section, cesarean section. Steroid therapy, betamethasone 12 mg IM, 2 doses 24 hours apart. Betamethasone 12 mg IM, 2 doses 24 hours apart. Again, because even this needs to enter my head too. Betamethasone 12 mg IM, 2 doses 24 hours apart if delivery is eminent before 37 weeks. Finally, coming to postpartum monitoring, BP monitoring for 48 to 72 hours postpartum, 48 to 72 hours. Continue magnesium sulfate for 24 hours postpartum, monitor for pulmonary edema, DIC or renal failure. Yeah, so with this we come to the end of this particular topic, discussion of this topic, eclampsia. In case you like this particular video, you can like it. In case you would like to comment something, you can comment about it. In case you would like to watch more of such videos, you can subscribe. Bye bye.